Thanks for checking back in to the True Sports Physical Therapy Podcast. Today's guest, Dr. Hugh House. This is my most wide-ranging conversation, and that's because Dr. House is an orthopedic surgeon, but he operates on hand, he operates on wrist, elbow, shoulder. We even get into some total knee stuff, which he does as well. He really does it all. And you'll hear in the conversation, he does an absolute bang-up job of educating his athletes as to the entire process, even ways to avoid surgery. And that's where we come in. We talk about ways to generate referrals from doctors like this. We talk about ways to connect and communicate with both patients and doctors. He shares some mistakes that sports PTs make, but he also highlights what it is he loves about our profession and how to do it better. So I'll let you guys listen to the conversation. As always, let us know what you think. Shoot us a DM, True Sports PT on Instagram. We have a host of continuing education courses that are now listed, so make sure you avail yourselves of that. Can't wait to hear from you guys. Let us know what you think. Without further ado, Dr. Hugh House. Welcome back to the True Sports Physical Therapy Podcast. I'm really excited about this conversation I'm about to have with Dr. Hugh House for a number of reasons. Number one, he's got his own pod. It's called House Calls. You got to go and listen to that because it is rare that we hear an orthopedic surgeon talk off the cuff. It's rare that we hear him take off the white coat and talk like a real human, and that's what you're going to find on House Calls. So go to Spotify. Make sure you're listening to Dr. Hugh House on House Calls. Dr. House, welcome to the pod, man. I can't wait to learn from you.
Thanks for having me on, and a great shout out for the podcast.
Yeah, absolutely. It really is an awesome podcast for what I just mentioned. Another thing that I love about some of your background is you're a well-trained orthopedic surgeon that actually has the balls to talk about exercise. So I can't wait to hear how you kind of came to that realization. Too often it's like, listen, I got to fix your shoulder, I got to fix your elbow or whatever. You clearly have a different approach and look. So why don't you regale the audience of sports PTs that we have listening to you, how you came to that realization and really what your outlook is to orthopedic medicine?
So really, I've been in practice for over 20 years, and I did my residency at University of Texas in Galveston. We did a lot of sports medicine, treated a lot of athletes, and it was back in a time where residents were really pretty much allowed to do their own thing. And then I did my hand surgery fellowship in Louisville, which was a trauma center, all hand, elbow, shoulder, lots of firearm injuries, people cutting off their arms. But when I came back to Maryland and started practicing, I found myself in a situation which I actually ended up liking. I was doing a lot of general orthopedics and was more of a referral center for hand. And as my practice has gone on, I see pretty much everybody. So I love seeing athletes, but I treat the whole family. And basically, my surgical volume comes from some of those patients, a lot of referrals from my partners or other orthopedic surgeons in the area. But in the office, you'll see me seeing everything. And I really realize that there's two groups of orthopedics patients. There's the fit person who eats relatively well. I don't think anybody is perfect, but the person who's out there working out, past middle age and old age, and they might have an injury and then they heal quickly. You might not see them again. Maybe they injure their rotator cuff and they're gone for 10 years. And then they might come back 10 years later, or you see their family. That's how you know they're doing. The other group of patients are bread and butter patients. I love seeing them. They're great people, but they might have 10 surgeries in 8 years, and they might come in 10 times a year, and they just have basically diseases of chronic inflammation. So we'd call it metabolic syndrome. So in medicine, you would think about it, the person who's on 10 medications, they also might be getting 10 surgeries versus the fit, healthy person. They might be on a medication or two at middle age, but a lot of people aren't on any medications. And if they get diagnosed with something, that person who might be told they have high blood pressure or high cholesterol, their first go-to is, what can I do exercise-wise and what can I do diet-wise to stay away from medicine or surgery? So that person who it's actually easier for them to work out every day than it is for them to remember to take a pill, that's the group I'm talking about. And that's when I realized that I'd love for more people to be in that fit, healthy group. And I can go on, but I really think that for somebody my age, I'm 56 years old, a lot of the information we were given on nutrition was wrong. And a lot of that information is getting much better now. Like we have an idea, there's different tribes kind of, but we have an idea of what to cut out at least. And knowledge is power, and I want that information to get to people. And then the other thing from a fitness standpoint is I love people doing the big bucket list events. My wife has done marathons. I got tons of cousins who have done marathons, and I love people who are that dedicated. But I always like to say the 2 miles you walk is better than the 4 miles you don't run. So some people, it's great, do those big things, but other people, they need to walk, they need to stretch, they need to do some push-ups, they just need to get moving, and that'll help.
That is a refreshing outlook. I think it blends our two worlds really nicely. How important exercise is, and so often we're really blessed at True Sports that we get a lot of patients in the bucket of, hey, I'm doing everything I can to avoid the knife or to avoid future injury. That's definitely our bullseye, and you're right, it is becoming easier to have those conversations. How do you have the conversations with the patients that is totally new to them? That they don't understand the idea of exercise. Meanwhile, they got this rotator cuff tendinopathy that they're working on. How do you introduce exercise to that population?
So I think about this a lot. There is definitely a balance between honesty and cruelty. So
Okay.
let's say you are overweight and you broke your ankle or you sprained your ankle. And I'm like, the reason you're having so much troubles is because you're too heavy or because you have no agility because you don't train or something like that. If they're in horrible pain, that is not the best time to bring it up. So in this day and age, it's definitely getting out in the culture. So sometimes people will say, hey, is there anything that I'm eating or anything I can do diet wise that will make me feel better or anything I can do fitness wise? So sometimes people ask me. Sometimes I feel like I have to say something. So if I see somebody with maybe early arthritis, most people in the community are not doing knee replacement or hip replacement if their BMI is above 40.
Mm-hmm.
So if you see somebody who's 30, 40 years old and they might have some early arthritis or moderate arthritis, now's the time to tell them. Don't let them get conservative care with medicines or injections or therapy for a couple decades, and then they finally come in at 55 or 65 and say, hey, I'd like to sign up for my knee replacement. And I'm like, oh, great. We'll get you signed up as soon as you lose 50 pounds. Like they could have had 2 decades talking about it. So I think you need to start telling people ahead of time, hey, this is something you need to keep in mind. So if somebody, even if they have, even if a college lacrosse player tears their ACL, you might want to mention, hey, you could get arthritis later in life. So keep that in mind. You want to keep your quadriceps as strong as possible. You want to keep your weight down. And I use the term BMI, and BMI has gotten somewhat criticized. But that upper levels of BMI where you're talking, can you get surgery or can you not get surgery? There's no debate at those higher levels. And that's not the weight where you have to look perfect in a bathing suit. You just need to be healthy enough that you can climb stairs, take your grandkid on a trail hike, have some agility, be able to prevent some falls, that kind of thing.
Yeah, I think that goes a long way. I'm thinking, while I have the luxury of treating athletes and elite athletes, it's definitely a skill to all the sports PTs that are listening to this pod to be able to educate, and not only educate, but to motivate your clientele to get moving. And there's a right way to do it and a wrong way to do it. It really, like your answer to my previous question reminds me of a book that we just did with what we call our Captain's Academy, which is the way we bring along leaders within True Sports. And we read a book called Radical Candor. And in Radical Candor, Kim Scott talks about the need to care personally and to challenge directly. And that's what you're talking about. The need to challenge directly and for it to come from a place of empathy, but the disservice you're doing to your patients by avoiding that tough conversation is astronomical. And the example she gives in the book is someone who has something stuck in their teeth, and it's uncomfortable for you to say something about something stuck in their teeth. Meanwhile, 20 minutes go by, that person has talked to 30 people, and they turn around and say, God damn it, Yoni knew I had something in my teeth. He didn't tell me. Think about the disservice you're doing that person by being scared to have that conversation. It's the same thing with health. God forbid that patient is ready for a knee replacement in 20 years and no one told them that they need to start working now to get ready for it. You're really missing a golden opportunity. So I think that lands well.
There's also something where when you are injured, you might feel better, but you still have damage in there. And you might not know it. So it's kind of like when you leave therapy and you've healed and you think you're great and your therapist is proud of you and they give you a high five and they give you those exercises and they're your home exercises. It's like, those are you forever. Like you need to do them forever. And I was just talking to a friend whose son is a high school lacrosse player. He hurt his back, looked at the MRI. He's going to be okay. But it's like, hey, this is his wake up call. He should do his back exercises 3 times a week, 5 to 10 minutes for the rest of his life, because he does not want to be 55 and not be able to play golf with his friends because of something he did when he was 17.
Yeah. And the lasting impact you can have on patients is enormous. I want to shift gears just a little bit. I want to talk about some of what you do in the OR. I want to know about some intraoperative decisions that you make as an orthopedic surgeon and how those affect your outcomes and how they affect my world of PT. Can you give me some examples of that?
So my surgical volume is generally hand surgery and elbow surgery. So that's the majority of my cases. I do some knee replacements and some knee arthroscopy. And I still do some shoulder arthroscopy and rotator cuff repairs. But my big thing is with that I use therapy for is with the trauma and the knee replacements. And the biggest thing is when we fix it, it's stable. So if your wrist is broken and I fix your wrist, it's stable. And so when I send you to therapy, I want motion and not we're going to wait for the swelling to go down. Hands can be sensitive. There's a lot of nerves in the hands. That's why you feel with your hands. So if you're swollen, if you're a little sensitive, that's when you got to move it. And people think, oh, I'm swollen, I got to wait a couple weeks for the swelling to go down, or I got to wait for the pain to go away. No, the pain will go away and the swelling will go down the quicker you get it moving. Same concept as for elbows, but even more so. Like if you immobilize an adult elbow, it is going to get stiff quickly. Even if it's the mildest sprain, you will never get your full elbow extension back. So once it's fixed, we're fixing it stable enough that we want that thing moving. And basically we need that coach cheerleader who's going to not only be working with them probably the 3 hours they have with them in a week, but also convincing them they need to be doing it at home. And I think the same thing with knee replacements. It's like those first couple days, getting that knee from 0 degrees of extension to 9 degrees of flexion is critical. And I spend most of my time when I discuss the risk and benefits of knee replacement surgery is just being like, the x-ray is going to look perfect, but I'm not replacing your ligaments. I'm not replacing your tendons. I'm not replacing your muscles. You need to get those moving. And if you get them moving quickly and everything's stretched out, you're going to feel so much better at 2 weeks out, at 4 weeks out. If you wait, then it's an uphill battle and your therapist is going to have to work their butt off when you could have done it your first couple of weeks or your first couple of days. Sorry.
Yeah. I mean, that is music to my ears. I think too often orthopedists are too hands off with that. They'll wait. I'm still seeing, and it's crazy because it's doctors with outstanding quote unquote reputations who are sending me ACLs 10 days post-op. And, we want to wait. And it just is not bared out in the literature, and it's mind boggling. So it's great to hear that you want to get your patients in and you want them moving immediately. We always say motion is lotion. Like the quicker you get that thing moving, the better off it's going to be. Do you feel the same way about rotator cuff repairs?
Rotator cuffs, I do, but I like it to be passive motion. So once it's fixed, I feel like it's stable. And what I'm worried about is a frozen shoulder. So,
Yeah,
is this all therapists listening or patients listen also? Because
mostly therapists.
therapists know that it's what a frozen shoulder is, but
Yeah,
that's what I'm worried about, because that's like the nightmare scenario. You fixed it and then you have a frozen shoulder. And we have Dr. Bear in our group who is a great shoulder surgeon, and that's why he does most of the big massive tears in our group. I still do the patient I've been treating forever who has a small tear. So when I fix them, most of my tears are stable and I want them moving, and I'm not too worried about if they do a little bit too much. I'm more worried about if they feel great and they think they can go lift weights or go skiing or something like that.
yep,
But that
yep,
has to do more particularly with the size of the tears I'm doing.
yep.
So, and don't tell Dr. Bear that.
I
That
will
he's
not tell
doing all
Dr.
the
Bear
big
that.
ones. No, he knows.
But
He knows.
but I think that's totally worthwhile, to understand the difference intraoperatively and how we should handle them. So small to medium tears, you're comfortable moving immediately. The larger tears, I don't want you to talk for Dr. Bear, but if you're doing a massive cuff repair, how long do you wait until they are allowed passive motion?
I like to get them passive motion within a week.
Okay.
So uh, a really big tear, people might wait longer, but you're still worried. You know, a big tear, you're putting a lot of suture in there, a lot of anchors in there. You're still worried about a frozen shoulder, and really, your repair should be stable enough that it can tolerate that passive motion. You may not want the active motion, but you at least can be doing pendulums and some, getting the shoulder joint moving.
Yeah. And can you just walk me through surgically what is transpiring, the difference between the massive tear and the small tear? How big of a size discrepancy is that? How much longer does it take you in the OR? This is stuff that a lot of PTs don't get to see firsthand.
So in general, most rotator cuffs, and I think this is where probably the public doesn't realize it. Most rotator cuffs are not the baseball player quarterback. It's mostly middle-aged people who are tearing the front of their supraspinatus, which is from impingement. It's our whole life of lifting our arm up. And nowadays somebody comes in with shoulder impingement. It's not that easy to tell on exam. Do they have a 1 centimeter tear? Do they have bursitis? Do they have tendonitis? So basically you treat them conservatively, which is physical therapy. And the studies show if the patient believes in physical therapy, they're going to get better, even with a rotator cuff tear. The other thing is that the vast majority of us, by the time you're my age, almost everybody has partial thickness rotator cuff tears. So you got to be very careful with the person who comes in with their MRI all circled up about their rotator cuff tear, and they're comparing their partial tear to their friend's completely detached supraspinatus and maybe infraspinatus. So you spend a lot of time making sure that MRI doesn't become the nocebo effect, which is the opposite of the placebo effect, where it gets in their head that they have to get fixed. They just can't imagine therapy can make them better. But when you get in there, a 1 centimeter tear, you're putting a couple sutures in there and anchor. The majority of their supraspinatus is still attached. So, about 3/4 to a half is going to still be attached. It's inherently stable. You can be pretty aggressive with that. If the whole tendon is retracted, as the whole tendon's torn and retracted back a little bit, then you might be doing a double row technique where you're putting a bunch of stitches in there, and you kind of want it to start welding to the bone a little bit before you're too aggressive. And that's where you might wait, 6 weeks before you start pushing them too much to get a little bit, because the sutures inevitably will fail. If you're depending on the sutures alone, they're going to rip through the tendon or rip through the bone. But that's also where the communication with the therapist helps, because you might get in there on a 65-year-old and their tendon is super robust. It's pulled away from the bone, but you put those sutures in there and you could water ski on the tendon once the sutures are in, and that's going to be solid repair. But they might be 65 and have the tendon of a 90-year-old, where you're like, oh, this stuff doesn't hold that great. And all you can do is put the sutures in and repair it down to the bone. Then you might be depending on the bone to heal to the tendon a little bit. And you might call the therapist and be like, we're going a little slower on this. We're just going to do pendulum exercises for the first couple of weeks and maybe limit their motion for the first couple of weeks.
That's where you're absolutely right. Communication is so important there. If I had a nickel for every time I got an email from an orthopedic surgeon in Baltimore about their shoulder and to say, hey, Yoni, don't push this one, that stuff is gold to the therapist. And to all the therapists listening, reach out to your orthopedic surgeons. And just because they don't respond doesn't mean they don't care. They just might be freaking busy. But you want to know what it is that transpired, because when you get a script that says evaluate and treat, we don't know what the hell happened in the OR. Any other questions we should be asking the physician before we get rolling?
I would say you want to know how they communicate, because you think about it, they might have a personal email that they look at every day. They might have a practice email that they don't even know how to find, and then they might have texts. So if you're seeing a lot of a certain surgeon's patients, you might want to have their text number, and their phone number. I don't think they're going to mind you texting them. They can look at it at any point, versus their email. They might operate on Wednesdays, be busy on Thursday. They may not check their practice email till Friday, and now you're 4 to 8 hours past when you want to get their rehab advanced, the patient's rehab advanced.
Yeah. I do remember, we're a direct access state, so we'll see patients that have not seen an orthopedist or a physician at all. I do remember an outstanding shoulder surgeon here in Baltimore lighting my ass up saying, Yoni, you needed to send this patient to me 2 weeks ago instead of trying therapy. What type of patient population that would come into me is an immediate referral to a shoulder surgeon versus, hey, let's see how you do with rehab?
I think it would be pretty rare for like a true sports scenario. I mean, certainly you could have somebody who has a fracture, and they come in thinking that they just strained it and it ended up being a fracture and you didn't have an x-ray. That could happen. But think about, in my mind, the stuff that's going to you guys would be like a labral tear. Well, if a kid comes in with a labral tear, a lot of labral tears respond to therapy. So the ultimate diagnostic tool for that is an MRI arthrogram, which means that you're sticking them with a needle to put the dye in the shoulder. So most of the time, even when you suspect it, you're looking at the mom and the kid and you're like, let's see how you do over the next 2 weeks. Now, if somebody had a dislocation, it's like, okay, let's get them into the doctor to evaluate it first before therapy. But most of the sprains and strains, 99% of those, we're trying to get them better with therapy.
I think it was a full thickness tear with retraction, and I think he was worried about the retraction.
Well, that's kind of funny to me also, because they don't it might be retracted, but if you have a healthy rotator cuff, you tear it, you treat me for 2 weeks, and then 2 weeks later it's retracted. That means it retracted years ago and I'd been living with it and just aggravated it, because they don't retract that fast.
Yeah. I'm going to tell that orthopedist to back off.
Don't mention me.
Quote you. Yeah. I'm going to quote you. Okay. One of my favorite topics, and by favorite, I mean challenging topics, is the world of hand therapy. I spent 2 years when I first got out of graduate school working in a hand center. Yeah. Between me and you, I wanted to kill myself. But why is rehabbing hands, why is it so much more difficult, at least to me, than any other orthopedic joint or surgery?
So there's a couple things. First of all, the tendon system is complex. So on the dorsal of the hand, the whole extensor mechanism, you have your extensor tendons, your lateral bands, and there's nothing there. Those tendons are smack dab next to the bone. So, and then skin, and there's a ton of scar tissue there. So that is challenging. And if you let that scar tissue get in there, then it's going to be hard to move them, and hands are sensitive. So you're basically like, I say it all the time in the office, I show them how I'm going to move them, but I'm like, I'm going to let the therapist torture you, or I'm going to let you torture yourself on your home exercises. Then the flexor side of the hand is complex. So if you have like a tendon laceration, in that area, you are depending on your sutures to hold because you got to get it moving. If you don't get it moving, it's going to scar in. If you move too much, you could rupture repair. And I actually trained with Dr. Kleinert, who was the first person to do flexor tendon repair in no man's land. And I treated him. I worked with him when he was 80. I was one of his fellows, but he when he first presented that to the Hand Society, they didn't believe him. The Hand Society, like all the big names, I think it was like Bennell and all the names you see in the textbooks, they came down to Louisville to see what Dr. Kleinert was doing, and he was the first one to do that early motion for tendons. That's just an example of how things can scar in. It's the same thing with fractures. When you fix a fracture, you want to get it moving. Like you said, motion is lotion. So it's that combination of how quickly stiffness can set in, and also how sensitive they are. And then it's still that thing in the patient's mind. They say, "Oh, I'm too swollen to move." And you're like, "No, you can move sausage fingers if you work hard enough."
Yeah, I found it so tedious. You know, you're dealing with like single joint motion. You're dealing with like your tendon glides. I was just like craving box jumps and gross motor patterns.
Yeah, I get it. It's funny. So our hand therapist is Jane Schmidt, and I've never asked her that question, but I bet she enjoys like the making all the splints, and that's a little bit different than general PT, because in general PT you might be ordering the brace, but you're probably not making the brace, whereas in hand therapy it's almost like arts and crafts. You're making a custom brace.
Oh my god, like I couldn't even figure out a stack splint, I think they call it. It's like the easiest splint in the world. That took me like 6 hours to make. It's not for me, but you're right. Every once in a while, like as I'm treating, I'm like, holy cow, like whoever created this human system it's bananas. And like the hand is a great example of that, of how it ever works properly, and post-op, all the just how tedious it can be. And I think like one thing that we tell our therapists here is, if it's a complex hand, send that to a CHT, to a certified hand therapist. Like they need to be in a setting where that's all they're doing, because of, like you're saying, like to make the splints, to really monitor appropriately, to know what's right, to know what's wrong. I think it's so specialized. We do see a lot of TFCC stuff. Can you walk me through the way you approach TFCC? What kind of repairs do transpire there, and the healing times?
So the one thing I'm going to say with any wrist problem, so even a kid with a broken wrist, an adult with a broken wrist, wrist sprain or whatever, you always want to pay attention to finger motion. You might think, oh, their finger motion will come back, but that is the priority, because if they got a stiff wrist, you can live with that. But if you have stiff fingers, that's a disaster. So with TFCCs, it's basically wrist pain on the other side of the wrist. And on exam, it's not always that easy to tell, is this a TFCC tear or is it ulnar tendonitis, or a number of things. And when you've been doing it long enough and you start seeing a lot of MRIs on older people, a lot of people have TFCC tears and are living with them and don't even realize it. So you basically try to calm it down. And usually I start with maybe some anti-inflammatories, some bracing. And then ultimately, if they're not getting better, I will consider an injection. Ultimately, if it's really not getting better, then I get the MRI. And that's when I talk about repairing it. It's not like a patellar tendon or a quad tendon where you're worried it's going to retract. It's not a timing thing like that. So it's pretty rare that I order the MRI immediately, because I'm trying to get them through without surgery, because I've seen so many people who are fine. That doesn't mean there couldn't be somebody who fell on their wrist. I'm like, okay, they tore their TFCC on the ulnar side and it's unstable and we need to get it. But most of the ones I'm seeing are more degenerative. And some of this practice philosophy is, things that have happened to me. Like I hurt my TFCC playing pickup basketball, and it was huge. I couldn't move it, but I rehabbed it and got better. And I'm glad I avoided surgery for it.
Yeah, for sure. Now, when you say injection in that instance, so we see this a ton in climbers. I think because of all the ulnar deviation, we see it a
Yeah.
ton in lacrosse players because of the flicking of their wrists constantly.
Yeah.
When you inject, is this PRP? Is this a biologic? Is it cortisone? Where's your head around
So
that?
if I think that they have a tendonitis, I'm injecting cortisone, um, and I'm not concerned with them getting a cortisone shot at their ECU, even in a relatively young person. But most young people are going to get by with splinting and Motrin and those kind of things. I'm thinking more like older middle-aged people. I'm going to tell them definitely try a shot. You might have had this tear for years and it's just aggravated, so I'm trying to calm it down. In a younger person, I'd be more hesitant to give a shot. I'd jump to the MRI and would be more aggressive in fixing it.
And this is a cortisone injection. You're
This
not
is a
doing.
this is a cortisone shot. So the deal with the biologics is, and I tell people I'm very open about this at any part of their body, whether it's their knee, their shoulder, their hip, or whatever, is that insurance doesn't cover it a lot of times. So it's coming out of their pocket for something that may or may not work. And I just say, if you played for the Ravens or the Orioles and you're a professional and you're getting $10 million a year and you're hoping not to miss a game, because if you do, you might lose your position or whatever, you're going to jump into stem cells and PRP right away. But for the rest of us, you might want to exhaust your conservative care and then you decide whether that's something you want to try or not try.
Yeah. I mean, I think that makes a lot of sense. Is the literature 50-50 on biologics around the hand and upper extremity?
I am not aware of a ton of information on like a torn TFCC, a
Yeah.
biologic even really being tested in that. I'd have to look that up.
Yeah. And then when you say splint it, rest it, how long are you given?
So what I'm saying is I'm basically giving them a cock up splint, but I don't want them to get too stiff. So I'm having them take it off a couple times a day and doing kind of full range of motion, but not having them do any lifting. And I really urge them to sleep in the splint. People don't always get that. They think I can take it off for sleep, but most people are going to sleep like this.
Mhm.
And if you're like that with a tendon problem or a TFCC problem, that's going to really make it bad when you wake up and you got to try to straighten it.
Yeah. Okay.
So I have a pretty straightforward protocol. I'm just like, you got ulnar wrist pain. We try to calm it down the old fashioned way. If you're middle age, I might try a shot, assuming that your problem has been there and you just aggravated it. If you're young, I'm probably going to be more aggressive on the MRI. But like if you're treating lacrosse players and stuff like that, a TFCC injury, even with the best surgery possible, is not something they want to go through.
Yeah, they're going to get stiff, and that's probably why we don't see a huge amount of them. And the few that I have seen have gotten really stiff. So I definitely understand you kind of waiting on it. We do get a handful, I would say, of total joints because we're so sports oriented, right? So 90% of our clientele are playing sports competitively, but we do see the athlete that has longstanding arthritis, wants to get back to some type of recreational sport. Where's your head around return to sport following something like a total knee?
Well, my first comment was going to be, you're going to start seeing way more because the longer you're around, the older you get. So the more gray hair you get in your beard, the
I'll take
more of
gray
your
hair.
patients.
I'll take any type of hair.
But the more of your patients that you treated when they were in their, teens and 20s, those people are going to be coming back to you when they're in their 50s if you're still doing this. So if you were really good with them with their rotator cuff surgery, they're coming back when it's total knee time. And my thing, I tell people, your patients will have a good results with total knees the longer they hold off. So if they think they're getting a total knee so that they can, be pain-free and play pickup basketball, that's the wrong person for a total knee. The person you want to do a total knee on is the person who just wants to walk pain-free. So I tell people, if you go be super aggressive, do whatever sport you want to do, and your knee's a little bit sore, you're not ready for a total knee. If it's Saturday, beautiful Saturday, and you don't go out, you stay home on the couch because your knee hurts so bad, then you're ready for a total knee. But ultimately, a total knee is more for somebody who wants to play golf, somebody who might want to hike, somebody who might want to bike, somebody who might want to play pickleball, doubles tennis, things like that. But now, as surgeons are getting more and more comfortable with the revision techniques, there are surgeons who are going to say, go do all these other things. So, like, if you're going to ski on a total knee, that's fine, but it's better for somebody who's a really good skier, like somebody who's a great skier who's then going to ski the blues or the intermediate slopes. It's not great for the skier who is an intermediate skier who's going to be like, oh, my knee feels better, I'm going to try the blacks. Because if you sprain a ligament around the total knee, or you break something around the total knee, that's a disaster. And so be very careful with that. Hip replacements seem to be different, though. First of all, hip replacement therapy is way easier. And if that hip is in there solid and stable, like I have a friend who I play pickup basketball with his hip replacement. We play lacrosse together with his hip replacement. He kind of will admit that he doesn't have the flexibility he had in that leg. He drags it along. But
it's stable.
He's able to do whatever he wants because he's stable. And if he wanted to ski or snowboard, he could, because he's a good enough skier or snowboarder that he's not falling. So it's like, drop it down a notch to be safe and you're going to be good.
Okay. And I mean, you get a total knee and you do go back to playing pickup basketball, or you go back to running? I hear this a lot. What is the lifespan of this knee? Are you really wearing it out? How long does it take? And what does a revision look like?
So when I first started in practice, they would say that total knees were like 15-year procedures. So that's why we kind of stuck with that 65. Now the implants, the materials, the metals, the plastics, the high density polyethylene, that should last for 40 years.
Wow.
So that's not your concern. Your concern is the connection between the implant and the bone. And that's what you're worried is wearing down. So if you are running on it, that's wearing down. And really, we would talk about it. We'd be like, you know what? Can you switch to walking or hiking? Why can't you ruck? Like, why can't you put a big weighted vest on and go for a walk? And if you are, this totally gets to another point of orthopedics, but I think orthopedics are not that interested in the psychology of the patient. For some reason, I have been interested in psychology ever since medical school. Is I talk to the person and be like, hey, can we figure out another way to treat whatever you're treating with these marathon runs with bad knees, that we can figure out another way that you can still get your outlet of exercise, but actually make sure these knee replacements last for the rest of your life. Because when you do a revision, you don't have as much bone to work with. And that makes it difficult. It is not like a car where you're like, oh, we're just going to put in a new brake system. The revision is a harder procedure. It's got a higher rate of infection. And it's actually getting to the point where there's kind of like revision specialists. There's people who are somewhat bored by just doing, bread and butter knee replacements. They want to do the big, really hard, difficult ones, which is great because the higher volume you get, the better you get at them. But it just shows you how serious it is. It's not like we're just going to do this little second knee replacement. It's a lot harder than the first one.
Yeah. I think it's pretty amazing that you're doing total knees, but you're an upper extremity guy. And so it begs the question, what makes an outstanding total joint guy?
So I think I trained at a different time. So
you're not that old, Doc.
I know, but there's a difference because I train the residents at University of Maryland now. So, and I have been for 20 years probably. And I always tell them every single one of them is going to go into fellowship and you need to go into fellowship. Totally agree with that. But when I was in training, so I finished residency in 2001. Half the people I was going into residency with were going to small town Texas. So their surgical day might be knee replacement, ACL, carpal tunnel, rotator cuff, and then maybe the neurosurgeon was coming in at the end of the day and they were going to fuse a neck together or something. And they were doing the flexor tendon in the finger. They were doing everything. So my program, we did tons of total knees, tons of ACLs. We took care of the prison system for the University of Texas. So we were doing ACLs by ourselves as twos for that hospital. It was a different time. That's what I mean. I
Okay.
don't think there's twos doing ACLs anymore. So when you got out of residency, you were very comfortable. And so I always enjoyed doing knee replacements. I always enjoyed doing the knee scopes. I honestly think that doing knee scopes on a fairly routine basis makes it a lot easier to scope a wrist, because you're constantly doing that triangulation, arthroscopy skills, and it does apply to the smaller joints. You're better at the smaller joints. It's not that easy for somebody who does not like arthroscopy to just start scoping wrists.
Yeah, can imagine.
So uh, so anyway, so with now, I tend to do the regular person with the mild deformity who just has no cartilage, bone on bone. If they have a weird deformity, then I'm sending them to one of the people who used to be my resident, who I've done cases with. I'm like, he's great, and then he went off to fellowship to do the crazy joints, and that's who I send them to.
Okay, and are you using gender-specific knees? Is there any validity behind using those?
So that's a scam.
Okay.
So when you get into a knee replacement, you're measuring the sizes and you're measuring the angles. So women might have a different size, they might have a different angle, but that was a marketing thing. You might do a patient-specific knee where you get an MRI scan beforehand, and your cutting guides are based on that patient. It gets into a little bit of when you choose to drive the Ferrari and when you need the Ford F-150. So you don't need MRI specific on every patient, but they might have something with some osteophytes or deformity where you want to have the patient specific. And then that gets into robotics,
Yep.
and the results for robotics and regular knee replacement are pretty much similar right now. I think it's promising in the future, but if you're a patient, you don't need to go run and be like, oh, I got to have the robot because it's the newest thing. Like, you don't necessarily want to be the first one to try the new thing, and you don't want to be the last person to get the old thing. So you got to be a little bit careful there. I think it's exciting, but right now it's a marketing tool. A hospital's like, we market the robot, and the companies will be like, we have a gender specific knee, because they want every female to feel like they have to have that knee. It's not like there's a pink knee that you're putting in there. It's you could have a guy who needs that same size. So it's an interesting concept, but I do worry sometimes when one of the companies that I actually used, they had a knee called the triathlon knee, and it was all these probably 25-year-old women with their hot hair dyed gray running across the horizon. I'm like, that's not, because then you're going to get people who, when they run, their knee gets a little sore, and they're going to think they need a knee replacement, and that's not who needs a knee replacement.
The marketing of surgical options, similar to like the marketing of big pharma, it is crazy what we allow, and the messaging behind it, and how it
Yeah.
fuels like the psychology, to use your phrase, of the patient. It's crazy to think about. Tell me, you're such a great person to ask this question because you see such a wide range of pathologies. What makes an outstanding sports physical therapist in your mind?
So I think one thing is they have to have a passion for sports. Like they actually have to understand not just the medical part and the therapy part, but how important this is for the athlete. So and how much missing a season can how difficult that can be for a kid, and realize I love this quote was, and do you remember Billie Jean King?
Sure.
So famous tennis player, when she won Wimbledon, like, or US Open or something the first time, there was a writer named Frank DeFord who actually went to my high school, and she said, Frank, you would have no idea what it feels like. And he was like, no, I know exactly what it feels like, because he won the 8th grade Baltimore City baseball championship when he was in 8th grade, because that was his whole world. So if your whole world is the MIAA championship lacrosse game, or the Anne Arundel County championship lacrosse game, or the state tournament, that's a big deal, and you don't want to miss that game. So you don't want a therapist saying like, you know what, you need to rest this injury so you can be 100%, when maybe you can rest tomorrow after the state championship game. You
Yeah.
never want somebody to cause more harm for a youth sport or a college sport. You don't want people to miss out on life in their 40s because of something they did when they were 17. But you also want somebody who understands that there's no long-term harm to this, to certain injuries, and let's get them where they can play, because the games matter. So it's that fine line, and I think understanding athletics and understanding athletes is huge. And I
Yeah.
also think understanding those concepts of coaching, of rehabbing, and using those same concepts to communicate with your non-athletic patients is beneficial.
Yeah, that's such a great answer. Such a great answer to the question. We know that the number one predictor of a true sports physical therapist is not what school you went to, is not if you did a residency, is not if you played sport at an elite level. And I mentioned those three things because those used to be the things that I look for when hiring. And I have totally gone away from that. And it is the number one predictor is, are you thrilled to be here? Does this get you out of bed in the morning? Are you super
Yeah.
excited about rehabbing the patient that's in front of you, or about the way we treat our model, our facilities, whatever it is? You have to love this stuff. You are definitely not in sports physical therapy to make $1 million. Like, you're here because you love it, and that's the number one predictor of success. I think that falls right in line with your answer there.
Yeah, you want the most passionate person, and we're both in the same situation as we have to teach our patients. I mean, ultimately, it doesn't work if your patient doesn't understand why you're doing these things. And like I've mentioned a couple times already, I want that patient doing therapy forever. Like there's the weekend warrior type who you see it a lot in this area. Like, think about the Fed Hill kid who is in the soccer league and the softball league and the basketball league, and that works in your 20s. But as you get into the late 20s and 30s, you start breaking down, and it's like when you get that person in therapy, that's your time to convince them to be like, hey, it's super fun playing these sports, but if you want to keep doing it, you got to commit, and you need to be doing your back exercises 3 days a week, your rotator cuff exercises 3 days a week, your legs, don't skip leg day. That's the perfect time to get to them, is when you're in therapy, which is so great about what you guys got, because you got the strength coach right there, you got the fields right there, and you could convince these kids to stay healthy forever.
Yeah, it's super important. I'll tell you, like, the most struggle, or the patient population that is so hard to educate around that, is the runners, because they
Yeah.
think that what they are doing is enough to keep them fit. And maybe cardiovascular, that's true, but you're not gaining strength by doing that. And sometimes positioning it as, hey, do you love running? This is the stuff you got to do in order to accomplish your love, or continue along with that love of running. That goes a really long way. If that's what makes a great sports PT, give me some mistakes our boneheaded profession can make at times.
So I think I'm going to go two things. Once we've already touched on is not pushing the motion enough, thinking that you have to do all the modalities to try to get the inflammation down and the swelling down before you move them.
Yep.
I've seen that before, and then it's kind of like, then you're behind the 8 ball, and that's where it's coaching to be like, hey, we gotta get moving through this. And the other thing is when things aren't going well, and things are going slow, yes, you should definitely communicate with the orthopedic surgeon, because if you start throwing out things like, maybe you need another MRI, or maybe you need surgery, and it's like, you've only been to therapy for a week and you're already saying you need surgery, call the orthopedic surgeon, because the orthopedic surgeon might be like, oh yeah, I've known this patient for 10 years, very anxious, she's nervous about motion, she doesn't need surgery. We can throw that out there, be like, hey, the chance of her needing surgery is 1 out of 20.
Mm-hmm.
Let's stick with the 19, but we're not giving up after a week of therapy, kind of. So as long as everybody's on the same page, because on the opposite thing, there's other people who are like, oh, okay, get them right back in. I need to see them today. I am concerned about something.
Yeah. Okay. Yeah. Great answer. Okay. To bring us home, Dr. House, I want to hit a lightning round, because
Okay.
you got a wealth of knowledge, man. So tell us the most impactful book you have read in the last 5 years and what it taught you.
Oh man, that is a tough one. I'm gonna tell you one that I just read that it's not the most. I read all the time, so I am reading several books a month. So if you're gonna say like the most impactful book, I'm gonna say like the Tao Te Ching or the Bible or something like that. But the one
Okay.
I just read that is relevant is Inner Excellence by Jim Murphy. Have you heard about this book?
No, tell me about it.
So uh, the Philadelphia Eagles wide receiver AJ Brown in I guess the first round of the playoffs was literally reading it on the sideline.
Oh yeah, I
And
remember him
all the
reading it.
ESPN pundits were like, is this a protest because he hasn't gotten enough targets? Is he complaining like he's bored so he's going to read a book? And in the post game press conference, he was like, no, this book is incredibly motivating for me. So I have sections highlighted and I was reading it between possessions to motivate me and keep me focused. And it is a great book, not only for athletes, but also for surgeons or anybody who's in a high performance area. And there are some, surgeries performance just the same way like a game is. So I thought it was very valuable. And that book was like something like number 1,000 on Kindle, on Amazon or New York Times bestseller, and it went up to number 1 because AJ Brown was reading it. But that's the one I would say for now.
Okay, I'm adding it to the list.
Okay.
Let me ask you this. If you could tell your 25-year-old self something impactful, what would it be?
Do my back physical therapy. And there is a story here. I hurt my back in a high school lacrosse game, in a summer league lacrosse game, and it bothered me through high school, through college lacrosse. I re-injured it. I missed the first part of high school football season my senior year. Hurt it again wrestling season, hurt me off and on through college, through medical school, through residency. My fellowship year, my wife and at that time 3 kids, I now have 4 kids, were back in Maryland for the summer, and I was in Kentucky by myself, and I saw my wife's abs of steel tape and I pulled it out. And my back pain after all those years from doing that motion and stretches and unloading my back pain went away. And I have been religious about doing my back exercises 3 times a week since. And I would have guaranteed you at age 18 that by 45, I would have had back surgery. Now, I'm not saying I'm not going to need back surgery when I'm 75 or 65, but like today, I feel pretty good. And it's from doing what is basically therapy exercises.
Yeah.
And core
Yeah, I
strength.
love that.
So,
Yeah, I love that. Of course I love that. Now, you and I share
so I
a
tell
near and
myself,
dear
do your therapy exercises
deal.
and do more sprints
And
because I
do
love
more sprints.
sports.
Okay.
Yes.
That's awesome, and it's clear that you love sports. That is, I was going to say, you and I share a dear friend in Dr. Austin Kolish, who just came out with his own continuing education course with our COO Tim Stone on how to rehab the elite athlete's low back. So there's definitely gold there, and there's so much. It's such a complex thing to rehab, especially when the guy won't give up the sport that's killing his back. They do an awesome job of breaking down how to do that. So shout out to them. You need to take that course, Doc.
Yeah, I do. Yeah.
Okay, we'll get you a discount code. Okay, your father is a freaking legend and was a Green Beret. The greatest
Yes.
lesson your father taught you was what?
Honestly, it was keep your options open, which meant whatever I was going to do, don't close your options. A lot of times he was talking academically. So he just meant, do the best you can because you don't want to miss out on anything because you didn't do well enough in school or well enough in sports. Kind of just keep your options open. He said it all the time.
Well, I mean,
but when I
as
didn't listen to him, when I didn't
No,
listen
you
to him,
did
he would
listen to
always say, I can buy him the books, I can send him to school, and all he does is eat the covers.
I love that. But you did listen to him as a guy who operates on wrist, elbow, shoulder,
Yeah.
knee. Yeah, you got your
We
options
do the
open.
exact same thing, actually. Our practice is almost identical. It's pretty funny. Yeah.
And he was also an orthopedist.
He was an orthopedic surgeon who did the same hand fellowship in Louisville that I
Come
did,
on.
and he kind of still treated everybody. And for him, a VIP was a high school wrestler. Like if
And
you were a high school wrestler, he treated you like a king.
that's amazing. And a VIP to you
Yeah, yeah,
is what?
yeah.
Who's your VIP?
Any athlete, I mean, really, I treat everybody like they're a VIP, but I do take special interest, especially in high school athletes and people who are on their way up.
Yeah, that is awesome. Well, Doc, I knew it would be wide ranging. I knew you would have a ton of wisdom. Give me some closing wisdom to wrap us up.
My closing wisdom is actually, I think you guys at True Sports really have something special with having the strength coaches, the fields, the weight training, and everything in one place. And one of my friends slash cousins, I got a lot of cousin friends, coaches lacrosse in Colorado, and she has had so many players go down with ACLs. And I really think the next thing is these ACL prevention programs and the weight training for the legs to make people more durable. And so having that strength component and doing that prehab for athletes. So, when they come in and maybe they had an injury, maybe it needed surgery, maybe it didn't, but actually taking care of the entire athlete and saying, hey, we have this back prevention program. It works for this person who's in the PLL. You should give it a try. But also, hey, you tore your ACL, your little sister or your little brother, they need to be in here also to get on those prevention programs.
I love that. Doc, checks in the
And,
mail.
and
Thanks for
honestly, I
thanks for
think
going
I
over
think
that.
that's the future. That's the future for orthopedics is to have everything, therapy, a nutritionist, maybe a psychologist, all of it in one place.
Hell yeah. Well, we're getting there. Tell your friends, send us all your
Okay.
patients. You're the freaking
All
man,
right.
Dr. House. I appreciate the shout out. I appreciate the time. Tell everyone what you're up to and how we can find your stuff.
So I am at 200 Hospital Drive across from Baltimore Washington Medical Center, practicing orthopedics in Chesapeake Orthopedics, which is a division of the Center for Advanced Orthopedics. I have a website with some of my blogs and then some of these therapy videos when you're not quite ready to go to True Sports
Yeah.
or our practice. At www, I guess you don't have to say that anymore,
Nope.
therealhousemd.com. And then my podcast is House Calls the Podcast with my friend Matt Waldron, who we've been friends for over 40 years. And he is there to make fun of me while we talk about serious issues, but also keep me in line.
Yeah.
And we
He does
talk
a great
about
job.
Yeah, we talk about sports, we talk about health, we talk about anybody who has a passion for what they do. So like when we had Austin on, he has a passion for physical therapy, he has a passion for lacrosse, but he also just has a passion for life. So we are trying to focus on maybe people who not only are kids who have a passion for something, maybe middle-aged people who are recreating themselves with passion, and even retirees who have found something that they love doing in retirement.
I love it. It's a great listen. You can find it on Spotify, anywhere your podcasts are downloaded. Dr. House, thank you for your time. Thanks for joining the True Sports
Yep.
Pod.
Thanks for having me on. That was fun.
All right, guys. Thanks for listening. Make sure you share it with your friends. Bye-bye. Bye-bye.